capacity. We're trying to encourage new researchers to get engaged in research in these areas. For the Southwest Ag Center in particular, looking at safety and health related research in agriculture. And so we try to do that by funding these projects and by mentoring our PIs and helping them connect with mentors and helping to support their projects as they develop. Vanessa, if you're online, would you like to share a brief welcome from the Southwest Ag Center?
Sure would. Thank you. Hi, good morning, everyone. Welcome to the third annual Southwest Center's Occupational Health Research Symposium, as Kevin said, and Jenil. We're so excited about this. I'm Vanessa Casanova. I'm the director of the Southwest Center for Agricultural Health, Injury Prevention and Education, or Southwest Ag Center, as we call it for short. And I'm a professor in the Department of Occupational Environmental Medicine here at the University of Texas at Tyler Health Science Center. And this symposium serves as a platform for showcasing cutting-edge research related to occupational safety and health as part of each center's respective pilot feasibility studies programs. The Southwest Ag Center strives to build capacity for research among junior faculty, as Kevin mentioned, as well as graduate students, medical residents, and researchers new to occupational agriculture, safety, and health through this particular program. This is an important endeavor in a work sector which includes agriculture, forestry, and logging, and commercial fishing, and also the highest fatality rate per 100,000 workers, and the third highest non-fatal injury rate per 10,000 workers. So thank you to each of the PIs for undertaking this really important work.
Thank you, Vanessa. And just to do some introductions, I'm Jenil, and I'm the director of the Pilot Projects Research Training Program at the Southwest Center for Occupational and Environmental Health. So just to reiterate, this symposium is basically a merger of these two pilot programs from the Southwest Center for Occupational and Environmental Health, as well as the Southwest Center for Agricultural Health, Injury Prevention and Education, that is the Southwest Ag Center. So at the Southwest Center, I'm the director of the pilot projects, and Dr. David Jimeno, he's the director of the center itself. So Dr. Jimeno, would you like to say some words of welcome to our audience?
Sure, thank you, Dr. Patel. Not to reiterate, but it feels like it's only the third one. At least for us, next year we're starting in July, the 25th year of the program. So we are for a celebration this coming year. But before we started, really, I just would like to express my appreciation for all of you who have helped to make this event come together after COVID, during COVID, and now on. And from my end at the Southwest Center at UTHealth Houston, especially thanks to Dr. Patel and Ms. Silvia Santiago, director and coordinator of the pilot projects. We couldn't do this without you. We certainly couldn't do it without the partners, Dr. Casanova and Moore and Amanda and others, UTHealth. I hope you'll hear from the 8 awardees today between the two centers that we cover, Texas, Arkansas, and Louisiana this year. There's a variety of occupational safety and health topics related to research, interventions, translational projects. And I hope that all of these will give you a sense of the possibilities that there are in the region and the passion that we all have for promoting and improving health and safety and well-being for workers. So I don't want to repeat what others have said, but we are very excited about this collaboration and we hope that it lasts for years. So I'm grateful to have you all join us here and thank you very much for listening. Back to you, Dr. Patel.
Thank you, Dr. Jimeno. And yeah, as he said, we will be celebrating the 25th year. So we have funded over $1.6 million over these pilot projects over the period of last 24 years. And many of these research projects have converted into peer-reviewed publications in top-tier journals and also have been translated to even R01 grants and to large-scale studies as well. So it has always been an exciting time every year to hear out these projects as to what they have been doing over the past year and what it is going to grow into. So these conversations that happen after these presentations, they really make a pathway for these PIs as well as their mentors as to what next steps we can do to foster this field of occupational and environmental health. So again, thank you very much for joining. We have here as our keynote speaker, Dr. Paul Henneberger, who is a senior science advisor at the National Institute for Occupational and Safety and Health, NIOSH. And it's a privilege for me to introduce himself, as I've also worked with him in the past, and several of us have worked with him in the past, including Dr. Jimeno, Dr. Delclos, and some faculty that are present here today. So Dr. Paul Henneberger is a research epidemiologist who is also the current science advisor in the Respiratory Health Division of the National Institute for Occupational Safety and Health, or NIOSH. He started his career in public health as an intern at the New York City Department of Health while working on his MPH at Columbia University, which led to a job as public health epidemiologist in the New York City Department of Health, where he conducted infectious disease investigations. Then a subsequent position opened up for him at the Environmental Sciences Laboratory at the Mount Sinai School of Medicine, which was the start of a career in occupational respiratory epidemiology for him. His doctoral work at the Harvard School of Public Health included a dissertation based on a study of the pulmonary functions of workers at a pulp and paper mill in New Hampshire. During 30 years at NIOSH, Dr. Henneberger has conducted studies of workers in coal mining, primary beryllium industry, agriculture, and healthcare. And much of his research has focused on work-related asthma and chronic obstructive pulmonary disease. He has mentored over 16 master's and doctoral level fellows, and along with the supervision, they have made 12 presentations at conferences and also co-authored 28 articles in peer-reviewed journals based on their fellowship work at NIOSH. Dr. Henneberger has collaborated with researchers in Sweden, Norway, and Spain, and participated on numerous international committees that published statements on occupational respiratory diseases. Notably, he was the lead author of the official American Thoracic Society statement on work-exacerbated asthma, and he has collaborated with our UT's own Dr. Delclos, Dr. Jimeno on nationwide asthma studies, as well as me on updating the Cochrane Review on workplace interventions for the treatment of occupational asthma. During the recent pandemic, Dr. Henneberger worked with a social media company to incorporate occupation into a daily survey on COVID-19. And that is what we are all excited to hear about during his presentation today. So without any further ado, I will pass the torch to Dr. Henneberger. Dr. Henneberger, all yours.
Okay, thanks, Jenil, for the invitation to speak. Thank you for that introduction. It's very kind. And I look forward to sharing some of my experience today. I also look forward to I can stay for a couple hours listening to others speak as well. So I look forward to that. So I will be, thanks for your patience. I will be speaking today about occupation as an essential demographic characteristic. The usual disclaimers, well, no, I have nothing to disclose. And the usual disclaimers, I don't speak for NIOSH or the CDC, and mention of any company or product does not constitute endorsement. So I'll start off with some background information about using occupation as incorporated into surveys. And then I'll move on to talking about collecting information on occupation during the COVID-19 pandemic, and then end with some summary and conclusions. So let's get started with the background. Well, as you know, I realize I'm preaching to the choir here, of course, but jobs can be risk factors for health, and it can provide insight into the health of individual workers and also groups of workers. And this insight can come as a result of jobs, because jobs include both direct and indirect risk factors for health. And by that, I mean direct as sources of harmful exposures, and I've called out some respiratory exposures here, including infectious agents, and also indirectly because occupations vary in the frequency of non-occupational risk factors for health and for health-related behavior among workers. And examples of these factors are gender, age, race, ethnicity, and education. Before we dive into this any further, how do I define industry and occupation? I use definitions from the Bureau of Labor Statistics, or BLS. And as indicated here, industry describes the business activity of a person's employer, or if self-employed, of the company or business. And an industry includes people with different occupations. An occupation is a category of jobs that are similar with respect to the work performed and the skills possessed by the incumbents. A job is the specific set of tasks performed by an individual. Now, there's been a number of professional groups that have recommended the routine collection of occupational information, going at least all the way back to 2011 in the United States. At that time, the National Academies of Science recommended placing occupational information in electronic health records. And their document said this information could enable improved individual and population health care through better informed diagnoses, more focused treatment plans, and improved and streamlined return to work guidance. Additionally, occupational information in EHRs could make notifiable disease and injury reporting more efficient, which could then contribute to improved surveillance of hazards in the work, reduce workplace exposures, and improve population health. Another recommendation from the Council of State and Territorial Epidemiologists came out in 2014 and was directed toward U.S. government systems. So the CSTE recommends that occupation and industry and other work information as appropriate be included as data elements within CDC surveillance systems where feasible. They went on to note that CDC surveillance systems, at least some of them, already collected work information. And then they added what I consider a prescient comment, given that it was 2014, which they stated the ability to capture work information, such as at a minimum industry and occupation within other CDC surveillance systems, may prove especially critical during emergency response scenarios like pandemic influenza. Well, as we know, we didn't have influenza pandemic, but we certainly did experience a pandemic 5.5 years after this statement. Another statement directed at U.S. government systems came from the National Academy of Sciences in 2018, was directed at the Health and Human Services Department, HHS, and that recommendation said that HHS should designate industry and occupation as core demographic variables collected in federal health surveys as well as in other relevant public health surveillance systems. Well, NIOSH has helped to implement these recommendations in different ways. One way has been to contribute to fulfilling standards for industry and occupation, or I&O, questions in electronic health records. And this has been a multi-year effort of working with the standard setting organizations that are still working along to come up with standard information and configurations for electronic health records. NIOSH has also been supporting I&O questions on national surveys, many of which I suspect you already know about, BRIFIS, NHIS, and HANES, and also by providing online support with the website collecting and using industry and occupation data. And this includes how to use NIOSH's industry and occupation computerized coding system, which is the free web application that converts industry and occupation text into standardized codes. And that continues to be improved. It's sort of in a loop of continual improvement. So it's the automated part has gotten very efficient. Now, here I'm expressing my opinions. How have people outside the occupational health community viewed recommendations for routinely collecting occupational information? It's been my observation that before the pandemic, skepticism was very common among many health professionals and largely a non-issue for the general public. But then during the pandemic, people in health professions, government, and the general public realized this information was important and should be used. And that collecting this information actually became more common, including in new online surveys. Now, I'm going to point out two of these surveys. The first one listed here is the U.S. Census Household Pulse Survey. And as indicated, it was run out of Census, and they used Census address files to reach out to the public. And the occupational information focused on 16 essential worker groups based on recommendations for allocating COVID-19 vaccines. Another online survey was the COVID-19 Trends and Impact Survey, or CTIS. And this was offered daily to a random sample of adult Facebook users. And the occupational information, which was eventually included, was based on the BLS 2018 Standard Occupational Classification System, or SOC system. And it's the second one that I'm going to be talking more about. And that leads me into the insights from this collecting information on occupation during the pandemic. Well, the CTIS was implemented by Facebook starting in April 2020, so relatively quickly soon after the pandemic started in the United States, and was continued into June 2022. As I already mentioned, it was offered to a random sample of adult Facebook users, actually all over the world, and approximately 20 to 40,000 US residents participated each day. The types of questions varied over time, but there were some core questions, including those related to demographics, pre-existing medical conditions, recent symptoms, social distancing measures, and COVID-19 test results. Now, Facebook collaborated with academic partners to both develop the instrument and modify the instrument and manage data transfer to researchers. And the Delphi group at Carnegie Mellon University filled these roles in the United States. So they shared de-identified individual data with research partners through data use agreements, and they provided sample weights to adjust results to the US general population. Well, Dr. Jean Cox-Ganser and I at NIOSH, when we learned about this survey, worked with the Delphi Facebook researchers to add survey items for respondents to indicate their occupation. And this actually was then implemented. We started in the summer working with them, the late spring, early summer in 2020, and by September 2020, CTS started collecting occupation. So respondents who responded to a question and reported working for pay in the last 4 weeks were asked for additional information. And specifically, they were asked to indicate where their job fit in a list of 23 major occupational groups from the BLS 2018 SOC system. And for 15 of the major groups, respondents were asked to indicate a more detailed occupational category that matched their job. Now, we had created these detailed categories based on, again, the 2018 SOC codes, and in particular, those for minor and broad occupational categories and detailed occupations. And there were a total of 120 of these detailed categories spread over the 15 major groups. Well, we started out by looking at pre-vaccine COVID-19 test positivity among working adults, and summarizing data from September 8th through November 30th, 2020, which was before the vaccines were available. And we focused on adult respondents who were working outside the home or were ever tested for COVID-19. And 13%, or 13.2% to be precise, reported ever having a positive test for COVID-19. And we presented summaries by occupation in a published article with the reference indicated here. I'm not going to talk anymore about test positivity, but instead focused more on the results from respondents reporting their vaccine status. So CTIS added vaccination questions to the questionnaire starting in December 2020, which as you perhaps recall, was when they started offering it vaccine to a limited number of people. And the criteria for vaccination was based on the question it was a simple question: have you had a COVID-19 vaccination? And the respondents who answered yes were classified as vaccinated. So it didn't get into how many vaccines they had had. It was just, have you ever been vaccinated? And we summarized responses by working adults who completed the survey in 2021. Now, some of these results that I'll be reviewing have already been published and appeared in the American Journal of Industrial Medicine in 2022 at the reference indicated here. So as I mentioned earlier, the vaccine, as you know, became available in December 2020. So, and based on the percentage of workers vaccinated by month, what we saw was a rapid increase in vaccination percentages in the first 5 months of 2021, matching what was observed in the general population, so that by May, there was some increase subsequently across the year, but nothing like the rapid increase in the first 5 months. Now, I want to talk about some selected results from this to show that how we were able to use these data to better understand trends, not only on the big picture, but in some more detail. Now, there are two major occupational groups in healthcare, and they both were prioritized for vaccination starting in December 2020. And while I've indicated the two major groups here and the detailed categories under each to give you some idea of what kind of workers are in each major occupational group, they pretty much reflect what the major occupational group title is. So for healthcare support, if you look at the specifics under here, it's a lot of assistants, dental assistant, medical assistants, and aides, nursing aide, home health aide, occupational or physical therapy aide, etc., vet or lab animal assistant. On the health practitioner and technician major occupational group, again, it's people who have more education and higher income than the healthcare support group. So there's pharmacists, any therapists, different nurses, licensed practical nurse, registered nurse, physician assistant, physician or surgeon, veterinarian. And what we saw from the data from CTIS was that early in, by January 2021, there was a difference in the vaccine uptake. Now, these data don't reveal whether it was a matter of access or whether it was a matter of acceptance by individuals or both. But the fact was that in January, there was a 20 percentage point split with a higher vaccination percentages for the healthcare practitioners and technicians. This was reduced to about a 15-point difference in February, 10 percentage point difference in March, only about 3 in April, and then by May, they were pretty much the same throughout the rest of the year. So even though both were prioritized for vaccination, both groups, the uptake was certainly very different during at least the first 3 to 4 months of 2021, which might be something to consider in other future vaccination efforts focused on healthcare groups, that if there's issues of access and acceptance to address, because these two groups certainly did not take it up at the same rate. Now, by April, May, 73.6% of all workers were vaccinated, and there was a considerable range among the 23 major occupational groups, with a minimum of 45.7% for construction and extraction, 87.9% for education.
We have sound?
Dr. H, I think we lost your sound.
Physical proximity to coworkers and or the public, and many of the detailed categories within these major groups were candidates for vaccination because all of the major groups included workers that the U.S. Department of Homeland Security considered essential to critical infrastructure. So here in April, May 2021, as I already mentioned, the very lowest group was construction and extraction at 45.7%, pretty closely followed by installation, maintenance, and repair. Farming, fishing, and forestry was third from the bottom with 53.9%. And others were spread out between about 60 and 71. And as we can see, many of these involve physical manual labor, such as transportation, material moving, production, building and grounds, cleaning and maintenance, food prep and serving, personal care and service, and also included in this group is military. Now, in the second half of 2021, for all workers, the vaccination percentage increased from 73.6 to 80.2, increasing from 73.6 in April, May to 80.2% in November, December. And for the 11 major occupational groups that I just highlighted in the last slide, all increased in the second half of 2021 with a median increase of 8.2 percentage points. However, military increased by 18.9 percentage points. And they really stood out from the other 11 because the next highest increase from April, May to November, December was 9.8 percentage points, about half of what the military revealed. And indeed, among those 11 major groups, military was the only major group with a universal vaccine mandate, vaccination mandate. So I think what we saw with the military was the positive impact of a mandate and really boosting the percentage vaccinated. Now I want to refer back to the April-May data, and in particular for the two different groups that had the minimum percentages, which was construction and extraction. Percentage vaxxed was only 45.7%, and about 40 points higher was the highest of 87.9% for education, training, and library. I'd mentioned that in my introduction, the background that occupations can have dramatically different distributions by common demographic characteristics. And what we see here is that education, training, and library, which had the highest percentage vaccinated, had tended to have much higher percentages of the characteristics that were associated with high percentage vaccinated. So, for example, women were more likely, females were more likely than males to be vaccinated, and the education, training, and library had an order of magnitude greater percentage than did construction and extraction. Education, training, and library also had a somewhat older population. They were more likely to be Asian, white, or black. And also they were about 3 times as likely to have a 4-year degree or more. And all of these factors were associated with having more likely to have been vaccinated. And in fact, when we control for these factors, these socio-demographic characteristics, we still see a difference between these two major occupational groups. But these distributions of demographic characteristics certainly seem to explain some of the difference between the two when we look at the raw values. Now, some summary and conclusions. So what happened with collecting occupational information in response to the COVID-19 pandemic? Well, questions were added to new surveys relatively quickly. Indeed, it took a while to get it on the CTIS and on the Census Pulse survey, but it was a matter of months, not years. So it was certainly it was timely enough that we could collect information relevant to the pandemic as it moved along. I think respondents provided useful results, both in terms of occupation. Most people who were working seemed to be able to indicate their own occupational category. We were able to make comparisons between occupations for frequency of vaccination and test positivity. We tracked changes over time by occupation, and the information could be used to supplement other public health data, for example, those data collected by state. And in fact, the survey data, the CTIS data, could be subset by state. And what did we learn from the CTIS data about COVID-19 vaccination by occupation? As I've shown, there was considerable variability by occupation. There was a rapid increase in vaccination percentages in the first half of 2021. Early in the vaccine rollout, vaccination varied by type of healthcare occupation, even though both of the two major groups I pointed out were prioritized for vaccination. Many occupations essential to critical infrastructure had lower vaccination percentages, even though they were essential to critical infrastructure. And in the second half of 2021, we observed the effect of mandates for the military, showing that the mandates did seem to have a profound effect. Now, what are some of the implications of these findings for public health? I think the information on trends for major occupational groups and also the detailed categories, which I did not talk about, could be used to help target messaging for behaviors as well, including health behaviors for vaccination, help design future studies on specific working conditions that contribute to the risk of infection, and lead to improved strategies to minimize infection and maximize vaccination in the future. And this is was important both for the COVID-19 pandemic and also when preparing for future infectious epidemics or pandemics. Well, in conclusion, again, these are my takes on what I've presented here. I think the collection and use of occupational information during the COVID-19 pandemic added credence to considering information about work as an essential demographic characteristic. And it remains important for all of us in the occupational health community to promote information about work as an essential demographic characteristic that will yield benefits for the care of individuals and the surveillance, research, and prevention of occupational and non-occupational diseases. Well, I want to thank several people, including all the Facebook users who completed the CTIS, my colleagues at NIOSH, as indicated here, as well as our collaborators and co-authors at West Virginia University, and also members of the Delphi group who provided critical support and guidance. And with that, I'd be glad to take any questions or comments or discussion. Thank you.
Thank you, Dr. H. That was a really great presentation. And I think one of the questions, I'm pretty sure we have a lot of questions from the audience, but just one point that I've always noted, because I do a lot of occupational exposure research in birth defects and birth outcomes. And one of the questions that always comes to our mind is, why is not occupation data collected the same way as basic demographics? And rather than it getting translated into multiple steps before getting into the real analysis plan, it would have been much easier to collect that data right away and treating it as a demographic variable right from the data collection to the end of the study. So that was very insightful, and I will open the stage to questions. I think Dr. Noor has a question. He has the hand raised, and then we'll move to Dr. Parkinson.
Good morning, Dr. Henneberger. Thank you very much for your great presentation. The question is about construction industry. Did the vaccination rate in construction industry ever get closer to the general population, general industries? Thank you. And also one more question. Yeah. You mentioned that military, they were one of the first which had a mandate, vaccination mandate. In your opinion, without the vaccination mandate in the military, where would military people would be in their rate of vaccination? Thank you.
Right. Gosh, remind me of your first question, having to do with
that was
oh yeah, the
construction
construction
industry. Did they ever get closer in vaccination
Yes.
rate uptake?
Right, they did not. As a group, they did not. I know there were individual groups that so extraction means mining, construction, and extraction. Like there were certain extraction groups like that had special attention. For example, Akshay Sood in New Mexico works with some a mining group that eventually did catch up. But as a group, no, they did not catch up. They were always the lowest. But from these data, and also the pulse data showed similar results. And in terms of the military, no, I think there was a lot of resistance in the military, as we saw that, and it certainly was on the news that some people in the military just left. You know, they resigned their appointments or left the military because they wouldn't take the vaccine. No, I think it was the mandate that really made the difference.
Thank you, Dr. Henneberger. I also wanted to share my personal experience that was in the state of New York City, that vaccination, it was mandate for healthcare workers to get two vaccines, otherwise they would be fired. And vaccination uptake was more than 99%, or people were fired. But when there was new vaccination mandate to get the third vaccine, about a couple of days before the deadline, still 25% of healthcare workers did not get the third vaccine. And so state and New York City governments, they backed down and they dropped the mandate because they could not fire the 25% of the healthcare workers. That probably was vaccination fatigue at that time. Thank you.
Thank you.
Thank you. Dr. Parkinson?
Thanks so much for an interesting presentation. I'm on faculty here at the UT Houston site in occupational environmental medicine. You know, I'm involved in an initiative right now where we're working to integrate more occupational health information into the electronic health records in conjunction with NIOSH's initiative. And one of the issues that I think we encounter is sort of the practical application of how to get that occupational health information into electronic record and who enters it, and taking a database such as ONET, for example, and trying to make that work into an electronic health record. And I you know, as we sort of struggle with that, just sort of the time that it takes to do that. I wonder what your thoughts are, if there's any discussion of how do we streamline a database such as ONET to make it practical that we can integrate it into electronic health records, and how do we keep it updated to continually as the nature of jobs change and job titles?
Well, I don't think I have any special insight. I think I mean I think it's people like yourself who have been, you just have to start wrestling with it as you have been doing. And I don't know what the secret formula is. I really don't. I mean, when Dr. Cox-Ganser and I configured the SOC codes for the CTIS, we were able to boil them down enough. And since they were presented electronically, it was a relatively small percentage of people working couldn't identify anything at all in terms that related to their work. But you're right. It's a struggle, and that's why I think it's just going to take some more struggling. I'm sorry, I don't have any more insight. But thanks for your work, by the way. It's important.
No, thanks. Yeah, no, appreciate it.
Thank you. We have time for one more question. So I'll let Thomas, Dr. Holcomb, ask his question.
Hey, Dr. Henneberger. Thank you for your presentation. I'm one of the occupational medicine residents. Currently taking a class in health promotions and behavioral therapy. So this is kind of more of a behavioral therapy or behavioral science question. Given that some of the theories are in behavioral science regard perceived severity and perceived susceptibility, did your research look at people who like subdivide out your groups of occupation by perceived severity and perceived susceptibility of to COVID regarding vaccinations? And then you can also think about COVID as being a disease that affected age groups and different subgroups of people differently in terms of morbidity and mortality. So do you think, or did you look at vaccination uptake in groups that had higher rates of morbidity and mortality and correlate that with perceived susceptibility and perceived severity?
No, we haven't done that. I mean, it's something that we're still continuing analyses. We're a little in NIOSH, we're a little removed from it because Facebook won't give the data to any government. So we are dependent all of the data that we could input. We could help change the questionnaire, but we can't directly accept the data from it because we're in a government agency, which is to say that we rely on our academic partners at West Virginia University to do the actual analyses, and it's something we've been moving through quite slowly. But we haven't done that yet, no. But other people who have used the CTIS data have done some analyses that at least are, well, there's one going on at Carnegie Mellon that's starting to look at some of the issues you just raised.
And would that also include prior infection status as well?
Well,
which would conceivably lower your susceptibility risk.
Yeah, so it's like the daily survey is like a series of cross-sectional surveys, right? So, but within any one survey and any one respondent, you're asking them both about their disease status as well as some of their attitudes. Then, in other words, have they ever had COVID? And then also their attitudes about the vaccine if they haven't taken it. So there is some of that information. Yes, it's not as granular as you might want, but there's some of that information. Yes.
Thank you.
Okay, thank you.
Thank you. So thank you, Dr. H. That was, again, a great presentation, and we really appreciate you coming and attending this symposium and for sharing your important knowledge. One thing we can't do here is big round of applause that we can do on WebEx, but I'm pretty sure those sentiments are shown by everyone. So in the interest of time, we'll have to keep moving on, and I'll pass it on to Dr. Vanessa Casanova, who will be introducing us with the Ignite format. We have the pre-recorded presentation, so she will give a brief overview of how these recordings were done, and then we'll be moving to our first group.
First of all, thank you, Dr. H, for such a compelling presentation, particularly on collecting occupational information in such an innovative way. And its importance for occupational health and safety surveillance, which anyone working in ag safety and health knows how critical this is. Let me just say again, we are delighted you are all here for the third annual Joint Pilot Feasibility Study Symposium. In order to highlight the importance of the work undertaken by each of our PIs and to take advantage of the collaboration between the ERC and the Ag Center, we will be using an Ignites talk format. Ignite talks are dynamic, fast-paced presentations that follow a specific format to deliver compelling messages. So Ignite is all about fast and fun presentations. Each of our speakers has created their presentations with 20 slides, each of which will be shown for 21 seconds and advanced automatically, giving each speaker 7 minutes to present their respective research. We've organized the symposium by creating thematic clusters, resulting in 3 sessions. We're reserving time at the end of each session for discussion, so please engage with our researchers by raising your hand for questions or typing your questions into the Q&A box. Each session will be moderated by staff. All right, let's get started.
Great. So can you all see the slide where we see the presenter names as well as the titles? Okay, great. So in this group 1, we will, the overall theme of this group 1 is general occupation and workplace health. And we have three presenters for this. The first one is Ms. Shelby Lambert from University of Texas Tyler Health Science Center, and she will be talking about using ROPS rebate program waitlist data to garner support for funding in Texas. Our second speaker would be Ms. Steven Wright from Sprout NOLA, and she will be talking about an agricultural navigator program for crisis response in Southeast Louisiana. And third is Ms. Lola Oluwafemi, and she's a doctoral student at the University of Texas Health Science Center at Houston School of Public Health, and her topic is the association between maternal occupational exposures and adverse birth outcomes among infants with birth defects. So with that, I will start playing the presentations with Ms. Shelby Lambert starting first.
Good morning. My name is Shelby Lambert. I'm the content strategist for the Southwest Ag Center. We're located at the University of Texas at Tyler Health Science Center. Today I'm presenting on my project titled Using ROPS Rebate Program Waitlist Data to Garner Support for Funding in Texas. To give you some more background on why we chose to do this project, as most of you know, agriculture remains one of the most hazardous industries in the U.S., and tractor rollovers continue to be the leading cause of deaths among farmers and ranchers, including tractor owners. Additionally, we know that the average age of tractors is over 25 years, and most of these tend to lack a key tractor safety device, which would be called a rollover protective structure. It's also called a ROPS or a roll bar, which would be retrofitted on the top of the tractor. We also know that ROPS are 99% effective in preventing injury or death in the case that there was a tractor overturn when used with a seatbelt. And we know that even older tractors can be retrofitted with a roll bar to help save a life. According to the ROPS R4U website, we know that 80% of deaths caused by rollovers happen to experienced farmers. 1 in 7 farmers involved in tractor overturns are permanently disabled. And we know that 7 out of 10 farms will go out of business within 5 years of a rollover fatality. Some problems we face when it comes to tractor safety are that farmers can't afford to retrofit their tractor or don't realize that they could be reimbursed for this cost. Or maybe they do not know that retrofits exist for their tractor, or they may not believe that tractors are dangerous or that a rollover could happen to them. Some possible solutions to these problems would be continuing to promote the National ROPS Rebate Program across the United States, as well as marketing tractor safety through social media campaigns, posters, and flyers, and then additionally finding funding sources for the programs in every state. More on the National ROPS Rebate Program. It does provide rebates for 70% of the cost of purchasing and installing a ROPS kit, and this rebate does cover a full ROPS kit with roll bar, seatbelt, shipping, and professional installation. Unfortunately, the caveat is its funding is limited and not available everywhere. So for this project, our aims included obtaining and analyzing the waitlist data from the National ROPS Rebate Program, using hotspot data to create strategic marketing campaigns to promote the waitlist enrollment, and then lastly, identify strategies for promoting the ROPS Rebate Program across Texas. During AIM 1, counties on the waitlist were entered into the Tableau cloud software to help identify the geographical hotspots in Texas. Conditional formatting was used in Excel to identify any duplicate counties, and these included Bexar, Hunt, Williamson, McLennan, Texas, Bowie, Wichita, Grayson, and Wood. The waitlist enrollment data was then entered into Tableau cloud software. This includes map 1, which was titled County Waitlist Enrollments, and it includes every county listed on the waitlist, and the range of enrollments was from 1 to 4. We found that Williamson County had the highest enrollment. Tractor rollover incidents were obtained from Ag Injury News. There were a total of 4 rollover incidents that appeared in the search, and this included Hopkins, Kerr, Erath, and Grayson counties. However, Grayson was the only county on the waitlist where a rollover occurred. During AIM 2, the graphics were adapted from the National ROPS Rebate Program national campaign with permission, and they were sized for social media, including Facebook and Instagram images. And then these campaigns will be used to promote to counties with reported rollovers. The last aim of this study was then to identify strategies for promoting the ROPS rebate program in Texas. This activity for the aim was to hold meetings with funding influencers to share the data that we've obtained from the waitlist and promote the program. We also met with the Texas Department of Agriculture and UTHealth. Unfortunately, we were not able to secure funding through these sources. However, towards the end of the study, funding did become available through an endowment fund, and we were able to reimburse 8 tractor owners for their ROPS kit. And we do hope to access a larger or more permanent funding source in the future. After reimbursing the farmers, testimonials were collected and will be used for marketing campaigns to help ads look more personal and relevant in the areas where farmers were reimbursed. This information can also be used for future waitlist enrollment campaigns to target counties with rollovers. Funding is limited or non-existent in all 5 states that the Southwest Ag Center serves. While strategic campaigns like this one are useful in promoting and increasing the waitlist numbers, they aren't exactly successful in garnering additional funding support. But even without promotional efforts, the waitlist continues to increase. Additional partners that could serve as possible funding sources or donors could be groups like County Extension, Departments of Agriculture, Farm Bureau on a local or national level, John Deere, other agricultural product suppliers, and we do think this project could be replicated in other states.
Okay, then we'll go to our next presentation by Ms. Devine Wright.
Hi, my name is Devin Wright. I'm the Policy and Research Manager at Sprout New Orleans, and I'll be talking about an agricultural navigator program for crisis response in Southeast Louisiana. So Sprout as an organization has programs oriented around 3 areas: community food, producers and sustainability, and land and equity. The Navigator program is mostly focused in this producers and sustainability area. The program itself was kind of piloted during the COVID-19 disaster, where Sprout was offering assistance to farmers in accessing supports that were available there. We found that there were a few different kind of overlapping circumstances that made it difficult for farmers to access COVID relief and to equitably access COVID relief in particular. So extrapolating from that COVID experience, we found that through conversations with growers, the reasons for the inaccessibility of those programs was mistrust of systems because of historical inequities and exclusion, confusion with poorly defined bureaucratic processes, and then a lack of patience, clarity, and time from agents disseminating these programs. We're hoping to address these issues through our Disaster and Crisis Recovery Navigator program that'll particularly be operating during a post-hurricane moment. We're going to leverage existing trust within communities to expedite recovery and hoping to create pathways and structures for long-term resilience and adaptation. So kind of revisiting our program structure, this Navigator program is mostly going to be under this disaster assistance category, but also touches on networking, farmer resources, and climate justice. So just to reiterate, the structure of the project writ large is comprised of formally developing and piloting the Navigator program, and then also evaluating that program. The program itself is intended to aid producers in accessing existing supports from disaster response and recovery programs offered by the likes of FEMA, USDA, et cetera. So the navigators themselves are going to be existing trusted community members, likely growers themselves. That'll involve substantial internal program development to ensure that those growers are knowledgeable enough and confident in their knowledge to be able to help other growers in navigating these kinds of systems. So what does that work look like itself? The work of the navigator starts after a hurricane occurs when folks are needing crisis support and access to recovery support. Navigators will help individual farmers to identify supports that they might be eligible for, apply for those supports, and simply offer a hand to hold during a really difficult time. Research comes in when we're asking questions like, what support do agricultural producers need? Does the Navigator program provide that needed support? And are there any potential unsustainable emotional and other burdens for program administrators or navigators themselves? And what does that mean in terms of the long-term viability of the program? So we're looking at this through a lens of mostly mental health. We're talking about community level resilience through the lens of individual farmer mental health or the relationship there. And then we're thinking through what is long-term programmatic sustainability in terms of navigator mental health. We're measuring this through 3 different methods. We're using an intake survey that'll use a perceived stress scale to get kind of a baseline for the grower. And it will also assess for an operational baseline, what was lost, what's needed now, prior experience in accessing recovery supports, and their willingness to engage in these supports now, which might be low. After about a month after the intake survey, we'll do an exit survey that'll also include that perceived stress scale for a point of comparison, and it'll ask folks about their experience with the Navigator program, as well as potential lingering recovery needs, skills that they learned through this process, and if they think they'll be willing to use those skills moving forward, or willing and able, really. Third, we will be doing focus groups, which will be weekly conversations with the navigators themselves to draw down those navigators' insights about program functionality and also to support the needs of the navigators. We're trying to attend to, or at least evaluate, compassion fatigue, secondary trauma, and ultimately long-term programmatic sustainability with this method. So opportunities that we see arising from this program include potentially creating a model that might be useful for other places. Certainly will need to be altered for context, but a generalized model nonetheless. Multifunctional resources that might be useful beyond the grower community or within grower communities in other places, and deepening our relationships with local existing partners. So folks that do disaster recovery and mutual aid work. Challenges in this project that we've experienced to date. Sprout is not a research-focused organization, so it's been pretty difficult and time-intensive to set up the structures we need in order to get IRB outside of academia. And then as far as hurricanes go, we're ultimately planning for an unknown but a certainty, which is a little bit of a tricky place to be in, especially considering that we do not have the ability to do the research until a hurricane happens. We do have a plan B though. Other challenges include that the disaster recovery landscape itself is constantly changing. So local, state, and federal actors, programs, funding is changing, and that's kind of difficult for us to proactively know with certainty. And then there's a lot of redundancy in resources that are available. So we're trying to consolidate where possible to make sure that growers have streamlined access to information, and so do our navigators. In terms of progress that we've made to date, we do actually have IRB in hand, which is really exciting for us. And kind of all of that entails for our research design being pretty well fleshed out, including having developed a relationship with our mentor, which has been really awesome. We have a program skeleton in place for the Navigator program itself. So what resources we're going to need, what we want those to look like, how to minimize redundancy, things like that. And then we've been able to kind of start having conversations with other partners that we work with in the food system and beyond about what collaboration could look like, what coordination of resources could look like in a way that I have did not necessarily anticipate, but has been really fruitful. So thank you all for listening to this presentation, and I apologize that I don't have more actual research to share with y'all, but like we said, this program is actually we're just actually heading into hurricane season now, so we expect that it will be launched soon, a kind of bittersweet situation. But thank you all again for listening.
Thank you. And now we are going to the third presentation by Ms. Lola Oluwafemi from UTHealth.
Hello, my name is Omobola Oluwafemi. I am a doctoral student at the University of Texas Health Science Center at Houston School of Public Health, and I will be presenting on the association between maternal occupation and adverse birth outcomes among infants with congenital heart defects. Birth defects are a major cause of infant morbidity and mortality, affecting 3% of all births. Congenital heart defects, or CHDs, are the most common type of birth defect and are the leading cause of birth defect-related morbidity and mortality. Adverse birth outcomes, including preterm birth and low birth weight, are the second leading cause of birth defect-related morbidity and mortality. The prevalence of these outcomes is twice as high among infants with CHDs compared to infants in the general population. Infants with both adverse birth outcomes and CHDs are at greater risk of complications compared to each risk factor alone. Risk factors for adverse birth outcomes include maternal phenotypes such as diabetes, maternal environment such as smoking, and maternal occupation-related exposures such as cleaning agents. The prevalence of these risk factors and maternal exposures varies across different occupations, and high-risk maternal occupation groups could be identified for interventions. Furthermore, the association between maternal occupation and adverse birth outcomes has not been studied among infants with CHDs. Therefore, the objective of this study was to evaluate the relationship between maternal occupation and adverse birth outcomes among infants with CHD specifically. We used data from one of the largest birth defect registries in the nation, the Texas Birth Defects Registry, from 1999 to 2014. We restricted our analyses to employed mothers of live birth singletons with critical CHDs, and this final analytic sample included 3,788 mothers. Maternal occupation and industry information was automatically coded using the computer-based NIOSH platform called NIOSH Industry and Occupation Computerized Coding System, or NIOCS. Occupations not coded by NIOCS were manually coded. Cases were infants with CHDs and adverse birth outcomes, and controls were infants with CHDs and no adverse birth outcome. Logistic regression analysis was conducted to assess the association between maternal occupation and adverse birth outcomes separately, and all analyses were conducted using SAS statistical software. Table 1 presents the demographic characteristics of mothers of cases with CHDs by term status. There were 712 mothers who delivered preterm infants and 3,076 mothers who delivered full-term infants. For all demographic characteristics except parity, there was a significant difference between mothers who delivered preterm versus full-term infants. Table 2 presents the demographic characteristics of mothers of cases with CHDs by birth weight status. 776 mothers delivered low birth weight infants and 3,012 mothers delivered normal birth weight infants. For maternal age, race, ethnicity, and hypertension, there was a significant difference between mothers who delivered low birth weight versus normal birth weight infants. Table 3 outlines the occupation groups of mothers of cases with CHDs by term status. There was a significant difference between term status for the two broad group comparisons, as well as for food preparation and serving related occupations. Table 4 outlines the occupation groups of mothers of cases with CHDs by birth weight status. There was no significant difference between birth weight status for any occupation group. Table 5 shows the crude odds ratio between maternal occupation and preterm birth. There was a decreased odds of preterm birth among computer and math science occupations compared to all other occupations. On the contrary, there was an increased odds of preterm birth among food preparation and serving related occupations compared to all other occupations. Table 6 shows that there was a protective association between computer and math science occupations and low birth weight, as well as between arts, design, and entertainment occupations and low birth weight. The association between maternal occupation and adverse birth outcomes has not been studied among infants with CHDs. We identified a few maternal occupations that were significantly associated with adverse birth outcomes. The Group 1 occupations that were significant were protective, while the Group 2 association was harmful. It may be because occupations related to management, business, science, and arts are less likely to engage in high-risk behaviors, such as smoking or drinking, compared to mothers of other occupations. On the contrary, women in food preparation and serving-related occupations specifically are more likely to engage in high-risk periconceptional behaviors. To further this research, I will conduct additional analyses adjusting for several confounding variables that are associated with adverse birth outcomes. Furthermore, future directions can include replicating this study in a control population without CHDs. Please see my references on this slide. I would like to take this time to acknowledge the following individuals for their contributions to this research. I would also like to acknowledge the Southwest Center for Occupational and Environmental Health for funding this project, as well as Texas Health and Human Services for providing the Texas Birth Effect Registry data. Thank you for your time and attention. I've included my contact information on this slide in case you would like to reach out or have further questions following my presentation. Thank you.
Okay, that concludes the presentations for our group 1. And next up is we have close to 20 minutes for a Q&A session for all these presentations. We have all the presenters here with us, so they'll be happy to answer all the questions. Shelby, Devine, and Lola. So with that, I'll open the stage for any questions that you all have.
Dr. Patel, can I go with a question?
Yes, absolutely.
Thank you very much. First of all, Dr. Patel and Dr. Olufemi. That's about the last presentation, general occupation and workplace health and maternal and infant comorbidities. So the question is, did you compare health insurance coverage for group 1 and group 2? In my opinion, those who work in administration and healthcare, they're more likely to be full-time employees compared to other employees, and more likely to have a full healthcare coverage, which significantly affects their proper healthcare management, proper management of pregnancy, and would help them to address any comorbidities or any adverse effects of pregnancy. Thank you.
Thank you. Yeah, that's a really great question. So the results I presented today are actually just the crude associations. So we do have several analyses in the works that we're going to include. And I think that's a really great point to point out because, yeah, work culture, access to information, healthcare benefits is definitely, I think, an important factor on occupational behaviors and also outcomes. And just as you said, just management of health conditions that these mothers will have access to. And so I actually have not gotten to that stage yet, but thank you for that. That's definitely something to consider along with additional factors, just thinking about demographic and just other differences between these maternal groups that could also influence these associations. Definitely something to think about.
Thank you very much.
Thank you.
And we have a comment from Jay Levine that it's a nice presentation and maternal occupational risks may also contribute to hypertensive disease of pregnancy. And they've also shared a PubMed link. So Lola, you may want to copy that from the chat box and see how that can help you improvise the project.
Awesome. Thank you so much for that.
Yeah.
Thank you, Dr. Patel.
Dr. Parkinson.
Great. Yeah, thanks. I hadn't intended this to be the NER and Dr. Perkison question panel, but I'll go ahead and ask this question. My question's for Ms. Devin Wright regarding the Sprout study. So when you're working with agricultural workers that have had their crops that year devastated by a hurricane, I was wanting to know if you had tied in any agricultural resources about perhaps advice of actual growing crops of crops that might be more resistant to drought or changing or resistant to the effects of flooding or saltwater incursion if it's near the coast, sort of trying to change advice as to actually what kind of farm produce to grow, if that was part of what you kind of offered for assistance.
Yeah, so as far as our disaster navigator program in particular, that is explicitly focused on in the acute kind of aftermath phase. So it's, after we're already a bit too far gone, but that I think is where a lot of the collaboration is coming into play. So we're working with, I think, 5 other food system organizations, including LSU Extension, which has a pretty strong presence in our area, to make sure that we have a bit more of the kind of wraparound services, quote unquote. And so thinking of, we're a pretty well-connected community, I would say, of producers in this area. And so trying to think through okay, if we're having a social event with growers, can we make sure that one of the people that's in this disaster working group, quote unquote, can have a presence at that space and walk through, these are the 5 things that you should probably do. If you're interested in, having a quick turnover crop in the aftermath or in the lead up, you might do radishes at this time, or small things like small hedgerows and stuff. So absolutely, that's part of the kind of larger, not necessarily framework, but the larger community approach that we're taking, but isn't necessarily explicitly part of the navigator program that's kind of acutely targeted at this specific moment of recovery. And I think that's the large, but obviously there's other parts of resilience in terms of the proactive work that's being done. So we're trying to hit that as well.
Thanks so much.
Yeah, absolutely.
Yes, Dr. Casanova.
Hey, great job to all the presenters. I have a question for Shelby. I wonder if you could, if you have an opinion about whether tractor rollovers in Texas are underreported. And then also, could you describe ag injury news?
Sure. Can you hear me okay?
Yes.
Okay. In my opinion, I would say yes, as I think most agricultural injuries are underreported just because of the nature of that population, as well as maybe it didn't result in a fatality. So maybe that worker was able to walk away from the injury. As far as the second question, Ag Injury News is a database where news is collected and reported on various agricultural related injuries and fatalities across the US. So we were able to use this to pull from that database and find the collected news stories that reported on tractor rollovers specifically.
Great. I believe there's a question on the chat box. And I don't know who Ms. Powell is, but based on the question, it feels like it's for Shelby. Are there any ROI estimates for each injury or death prevented by a retrofit?
I cannot tell you the exact numbers because I don't have that in front of me, but based on research that's already been done, it's been shown that, lots and lots of money. I mean, we're talking in hundreds of thousands, if not millions, are saved when workers implement these safety protocols and instruments versus taxpayers and other individuals having to pay for those injuries that have taken place. So I would say, as far as an ROI, it is definitely beneficial for the worker, for taxpayers and other stakeholders to invest in something like a roll bar that costs, anywhere from $700. We're saving hundreds of thousands of dollars in the long term.
Thank you. Dr. Holcomb.
Yeah, thank you for that presentation. More of a comment than anything else. On the Netflix documentary, Formula One Drive to Survive, they talk about the introduction of the roll bar or some kind of variant in Formula One racing. And a lot of people were upset at the roll bar being implemented because it affected their vision. But then they make a big point of talking about how it's directly led to people surviving pretty bad crashes. Formula One has very terrible crash when you look at when you watch the videos of it, they look horrendous. But the safety features that they have there are actually pretty robust, and the roll bars contributed towards survival of a number of crashes, including on the documentary. So I just thought it was pretty interesting. Also, the documentary is really, really interesting, fun to watch, entertaining. So if anyone's looking for something good, I recommend Drive to Survive.
Okay, Dr. Noor.
Dr. Lambert, again, great presentation. Question, I understand that currently in the 5 states of the Southwest Center, roll bars are not covered, but what about the efforts to get the greater outreach and education about the safety of the roll bars? Do you think it might help to make farmers to cover the cost on their own, or to find other source of funding? Do you think it might help also, not only roll bars, but also the seat belts? Thank you.
I'm just going to clarify. I don't have my PhD. I just have a master's degree. I just wanted to say that. But I think you cut out a little bit from what I heard. You're asking, or you're saying that we have only coverage in certain areas. Obviously, this program was focused on Texas. This is something that we would hope to implement in our other service region, and as well as across the United States. There are other states with funding, and that has come from various sources. Obviously, we would encourage farmers to put up the upfront cost of purchasing the roll bar so that they have it in hand, and hopefully one day they can receive a rebate for that. There are efforts in other states working with Farm Bureau organizations, other private funders to secure that funding. Obviously, we're trying to work with groups like the Department of Agriculture in each state, again, to find funding in their budget so that this can be more permanent source of funding for producers. In the meantime, I would encourage them, if they have the funds, to purchase the roll bar, get it installed, so that they can protect themselves and their workers and their family members. And through this program, we're looking for ways to promote it in other states. If the wait list continues to increase, it just shows that there is a need and the desire to have the program in their state, and hopefully that will encourage funding sources, if that answers your question.
Yes, it does. Thank you, Ms. Lambert. I appreciate it.
And I might add to what Shelby said. The Ag Center that initially started the roll bar retrofit program is out of New York. And they have also, they're the ones that did all of the wonderful ROI research. So that's definitely some publications that we can point you to and put into the chat. But they also did a really extensive marketing campaign, a social marketing campaign, and they discovered that the motivation that is most impactful to tractor operators is when they talk about the ability of the owner operators to protect their families. And this is pretty common in what we see in other agricultural operations. So a lot of their campaign materials said things like, of course it won't happen to you, but what about them? And it would be a picture of a father and his 2 children. So there are really great outreach campaign materials available to encourage the purchase of roll bars and the use of roll bars with seatbelts.
Thank you. I just wanted to comment that oftentimes medical doctors also use a similar approach, especially with behavioral or mental patients, when they appeal to their families and what effect it might have, any consequence which might have on the families, any adverse behavior of mental patients. Thank you.
Excellent. Yes, Austin Mills.
Hello, Lola. So as your research progresses, have you considered providing information to healthcare physicians? That way they can relay information to expectant mothers on occupational risk factors that kind of contribute to congenital heart disease. That way expectant mothers can kind of catch on to early signs for recognition. That way they can prevent any comorbidities within their children.
That's a really good question. I also do like birth effects research outside of occupational work, like genetics and other risk factors. And so I feel like when I'm doing that side of research, I think we do kind of talk more about how does this work in the clinical setting, like you said, relaying it to physicians. What are maybe some testing that can be done? What are some preventative measures the physicians can make the mothers aware of? But on this like occupational risk factor end, I think our first step has kind of been more of maybe what are workplace interventions that can be implemented? What are some maybe health promotion actions that can be implemented into these occupations? But I do agree with you. I think even in occupational research, ultimately, I think we need to still be communicating with physicians, which I'm kind of used to thinking about when I'm looking at non-occupation based risk factors. But I think, yeah, a lot of occupational studies kind of are like, okay, so how do we implement this in the workplace and what do we change about the workplace? But I think your question's a good one. And yes, I do think that should always be a consideration of also including the physicians that the mothers are communicating with and who are the ones that are kind of hopefully kind of guiding the mother towards behaviors and risk factors to think about, as you said, to prevent these adverse risk factors. And yeah, so I think that's a great consideration and something that I will definitely consider.
Thank you, and thank you everyone in Group 1 for your presentations.
Thank you.
Thank you. I think Devin has a question or a comment. I see you raise hand?
Yeah, can you hear me?
Yes.
Great. I switched to a headset. I just had a question for the rollover. Kind of seems like there's a team of folks here. The rollover folks. Did y'all have any kind of insight into like peer influence at all? And like, yeah, if there was, besides like a kind of county level clustering, but if there was like really proximal clustering, or if, you know, like social connections mattered at all?
Hi, Devin. I'll answer that for you. So we were able to obtain all the waitlist data from the New York Center that collects it through their online form. So when a producer signs up for the waitlist to receive the rebate, they put in different demographic information. It is limited when they ask the producer about how they heard about the program or why they were interested. And based on what I saw from the data, it was mostly they heard about it online. They were already looking for a roll bar. They saw it in a magazine or they heard it from a friend. I would have to do some more digging into that to see, you know, what were the reasons why they chose to do it. But we were really more interested in where were the clusters of people that signed up.
Thanks so much. Wonderful presentation.
Thank you. Any more questions? Yes, Dr. Moore.
Hey, Devin, you mentioned this concept of sort of helper fatigue, and I was wondering if you could talk a little bit more about those challenges and what you've seen in some of your preliminary studies.
Yeah, absolutely. So because the program itself is predicated on navigators being trusted community members and having kind of quote unquote skin in the game, they are often folks that live in New Orleans or in our kind of Southeast Louisiana area and are at risk themselves personally. They are also often farmers themselves. So they are simultaneously, as they are supporting people in recovering, often are recovering themselves. And so are splitting priorities between, do I help my grower community? Do I help my personal community? Do I help my family? Do I go and prep my farm, or do I go and help prep someone else's farm? So there's a lot of not necessarily issues, but there's a lot of like really quick decision making that has to happen. And then there's a lot of fatigue I anticipate and also kind of have seen that comes out of it in terms of compassion fatigue and burnout that happens from hearing stories of people not getting the support that they need and also not getting the support that they need themselves. And that's one thing that I have, so I'll kind of like back up a little bit and give a small anecdote. So we had Hurricane Zeta in 2020 that was like fairly damaging in Southeast Louisiana. And then in 2021, we had Hurricane Ida that was very damaging. You can talk to most people in the kind of quote unquote regular population, and they're like, oh yeah, we had a hurricane in 2020 and then another one in 2021. You talk to farmers and they describe it as being back to back. You talk to people that are in the farming community and those are back to back farms or back to back hurricanes, which means that the like time collapse for farmers is much more severe. And so the potential for burnout and fatigue and the need for services feel like much more collapsed for folks. And so trying to attend to and have kind of like a long purview, 30,000 feet in the air view of what is going to burn people out in terms of providing services to folks. Are we going to have to be doing this every year? And the answer is increasingly likely yes. And how do we make sure that the people that are providing these services can continue to do that and not after 3 years say, I have to move to somewhere else where the risks aren't quite as high and the costs aren't quite as severe to me personally, if that makes sense. Sorry, that was kind of a long-winded, winding answer.
That's good, Devin. Thanks a lot.
Devin, I have a very quick question, and it's probably a minor question, but you mentioned in your challenges that you do not have, since this is a non-research based organization that you represent, have you considered collaborating with researchers, mainly for a good quantitative approach, as well as getting all these logistics like IRB and all those settled out faster?
Yeah, I have a bit of a research background myself, not necessarily in quantitative approach. So I'm much more of a qualitative researcher myself. So no, haven't necessarily considered getting a quantitative approach. I do really like the mentor that we're working with. And so I'm excited to continue working with him and potentially figure out more collaborations. I will also say that folks in South Louisiana, Southeast, and Southwest Louisiana in particular are a pretty intensively over-researched population. And so we're trying to be like very, very careful and intentional about the ways that we ask growers in South Louisiana in particular to come into research spaces because they are so frequently asked for input. Southeast Louisiana and New Orleans in particular has the highest number of nonprofits per capita. So between disaster research institutions and nonprofits that are doing evaluation, folks are getting asked to respond to questions and things like that all the time, which I guess maybe makes the case for quantitative work even more useful.
No, that is great. Okay, so in interest of time, I think we're just running 3 minutes over, which is not bad. We can always catch up with that. I think these were some really great presentations. Congratulations to Shelby, Devin, and Lola for such excellent presentations and for all the wonderful work you have been doing. I think we can conclude our session 1 right now and go for a short break. We all will resume back at 10:10, where Dr. Moore will be moderating session 2. We have Priya Dasgupta and Oshin Tyagi, so I'll be playing their presentations, followed by a discussion similar to this. Thank you, everyone. Okay, so welcome back, everybody. It's time to begin our session 2. So Dr. Moore, would you like to introduce your speakers, and then I'll go ahead and play the recordings.
Yeah, great. Thank you. So for group 2, we have 2 presentations. The general theme here is exoskeleton physical therapy. So we have Dr. Dasgupta and Oshin Tyagi as our 2 presenters. Dr. Dasgupta is with Southeastern Louisiana University, looking at targeted exercises for preventing work-related low back pain and discomfort in construction workers. And then Oshin Tyagi looking at task-based evaluation of exoskeleton fit and how that works, the effectiveness of that, and neurophysiological costs. So we'll get started with those 2 presentations.
Great. Get started with Dr. Dasgupta.
Good afternoon, everyone. My topic is importance of targeted stretch exercises for preventing work-related low back pain and discomfort in construction workers. The reason that I was trying to do this research was overexposure of the construction workers towards a lot of low back pain risk factors and hazards, and that a lot of construction workers are also getting involved into pain medications to treat those back pain, and they can go up to certain extent of using opioids. As you can see that SAMHSA has some data regarding the use of illicit drugs like opioids and pain medications for construction workers. SAMHSA is Substance Abuse and Mental Health Services Administration. They have compiled the data of the study that suggests that there are some complex issues, which is basically how construction workers are getting involved into it. Like they want to treat their outcome of the pain. They do not try to find out what is the resource of their pain, that is a lot of unergonomic postures and manual load handling. They go to the doctors treat their symptoms, they get rid of the pain, they come back, they join their workforce again, and they, of course, the pain deteriorates because the source have not been targeted. SAMHSA also have shown that there has been, to a certain extent, marijuana use by different industries. As you can see in the last 3 slides, that construction was at the top for the use of opioids or marijuana or some illicit drug usage. The construction workers are some way unaware of the epidemic. What we are seeing as a result is a lot of construction workers are being suicidal because of depression and mental health disorder. There have been reports by SAMHSA where they show that construction workers are at the highest rate for using heroines also. As far as the pain reliever goes, construction workers are using it at a high rate. 22.63% of all construction workers are getting involved into pain reliever medication. What happens is a chain of different types of actions. They go to the doctor, they get treated with some opioids. There are some extra opioids they might not need, but they can keep it with them. Of course, when another construction worker says that they have the same type of symptoms, the first construction worker can, of course, lend the extra opioids to the second construction workers, and that is how the chain is going on. Just wanted to tell you that what are opioids. These are actually used for acute pain. They usually are not addictive, but if you are taking a lot of them and frequently, people do get a type of addictive on them. One study has shown that 42% of workers who were injured on their backs on their job, they were prescribed opioids with a year after injury, and 16% of those workers were continuously prescribed opioids. In the construction industry, we have done a thorough research. In addition to the bibliographic research, we went to different construction sites and we found out that there is a huge amount of opioid addiction, and that is currently the country's #1 public health crisis, and the construction industry is just showing a harsh reflection of that fact. Me and my students have gone to different types of construction sites. Of course, we did not ask them directly about opioid, but we tried to get some idea about how the construction workers are treating their pain. So many of them have said in focus groups, we did the focus groups, and there they have said that they are indulging into the opioid just because they want to treat their pain. They have not thought about treating the source of the pain, which is their awkward postures. When we asked that whether they know about ergonomic postures and whether they have gone through the training process, they say yes, they are very confident on the training process. As per our whatever we wanted to do for this grant. We went to different construction sites. We made them we divided the construction groups according to our cases and controls. However, one main part of the study was that the construction sites will get the physical therapist's talk. And the physical therapist, as you can see in this picture, is giving them a huge detail, a whole lot of detail about why the exercise and stretch exercises will work. These are the results of the study. You can see here that how many of them have said that whether they know about the stretch exercises. The first slide show you two different construction sites combined data. They told that some of them really go to the extent of pain medications, extent of opioids. This is the data where I'm showing you that how many of the construction workers were interested in getting the physical therapy session. To our real excitement, 17 out of 20 construction workers in two sites, they have said that after this physical therapy lecture session, they are very much interested in go to the stretch exercise program, and they will do the stretch exercise program as per the physical therapist has shown them. The main topics that we have discussed in the focus groups were what are the reasons that the workers were not using the stretch exercise. Some of them told that we are so young and we have very good musculoskeletal system right now. We are not old people who would need it. People who have said that they really wanted to have the stretch exercise, they told that they do not want to go to the doctor because if there is a need to go to the doctor again and again, they won't like it. Rather, they would be adopting the stretch exercise as a preventive medication or preventive therapy. And some of them said that we do not like it at all. We have never liked it. We will not do it in the future. There are many more components that were discussed in the focus group. Because of the time issue, I'm not going to tell all of it, and these are the selected references. Thank you.
Okay, and our next one is Ms. Oshin Tyagi.
Hello, I'm Oshin Tyagi, and this study is an evaluation of passive low back exoskeletons for EMS work. Introduction and motivation. Emergency medical technicians have higher rates of musculoskeletal disorders compared to the general workforce. Approximately 34.6% of full-time EMTs experienced an injury at work, where the lower back was the most injured part of their body. Current MST's risk mitigation techniques listed on the left offer incomplete protection when handling unique cases, and the forces on the lower back are still at the at-risk zone. Passive low back exoskeletons can be implemented into EMS work to further mitigate risks to EMTs, since they alter the worker instead of the workplace and are therefore suitable to support EMTs. Passive low back exoskeletons support workers' mobility and limit exertion, and therefore decrease spinal compression and increase user endurance for repetitive static lifting tasks. However, their benefit or limitations for tasks involving more complex movements and high ranges of motion are not well investigated. Due to the unique nature of EMS work, evaluations of static lifting tasks are not fully representative of the typical work performed by EMTs. Thus, this study focused on the subjective evaluation of participants' perceived workload, discomfort, exertion, and perception of the exoskeleton with respect to dynamic tasks. Methods. The demographic information of the 20 participants in the study is shown here. The participants consisted of 18 males and 2 females from a local emergency medical services department. The exoskeleton used for the study was the soft body HeroWear Apex exosuit, which uses high resistance rubber bands to assist with heavy lifting. Address the unique task demands of EMTs, participants perform tasks from the PAT, or the physical agility test, a timed event designed to simulate critical physical tasks performed by EMTs during emergency situations. The participants perform these tasks in a continuous circuit with and without the assistance of the passive low back exoskeleton, with the conditions being counterbalanced. The modified PAT circuit performed by the participants began with task 1, where the participants lifted a backboard with a 60-pound dummy patient from the floor. In task 2, the participants carried a cardiac monitor in one hand and climbed stairs. For task 3, the participants climbed and descended a staircase with a 75-pound barbell, which used to stimulate half the weight of a patient. The fourth task had participants pulling and pushing a loaded stretcher out of and into an ambulance. The fifth task required them to perform CPR for 2 minutes. The circuit then concluded with participants repeating the backboard lifting task. A 10-minute break was provided between each circuit to alleviate accumulated physical fatigue. 6 different surveys were conducted with each participant throughout the experiment. Between each task, the participants were asked about their ratings of perceived exertion and mental demand, adapted from the NASA Task Load Index, or TLX. After each circuit, participants provided ratings of perceived discomfort for different areas of their body and responded to the complete NASA TLX questionnaire. The Technology Acceptance Model, or TAM questionnaire, was administered 3 times after watching an instructional video in the beginning of the study, after performing the circuit without the exoskeleton, and after the circuit with the exoskeleton. The Exosystem Use Intent Model, or the EUI, was used after performing the task with the exoskeleton to gauge the EMT workers' inclination to use the exoskeleton for work specific to their field. Next, let us evaluate the results. The results from the RPE questionnaire demonstrate that exoskeletons did not significantly affect the exertions perceived by the participants, but it did reduce their perceived workload, as shown over here. As shown in the figure, the results from the NASA TLX survey indicate a significant decrease in mental workload, specifically for physical demand, temporal demand, and effort, when participants completed the task in the exoskeleton condition as opposed to the control condition. Additionally, the RPT results indicate significantly lower discomfort in the lower back and shoulder when using the exoskeleton. The result is of great significance since previous studies have reported increased discomfort when participants wore exoskeletons with hard body frame. This suggests that the exoskeleton with a soft body design like the HeroWear Apex suit that was used for this study may be more suitable to use in a highly mobile work environment like those which EMTs often work in. Results from the TAM model indicate that although participants believed their interactions with exoskeletons were clear and understandable after they used the exoskeleton, they did not believe that it would lead to a significant increase in job performance. The results from the EUI survey show that for the most part, participants found the device to be easy to use and had positive attitude towards it. The overall scores show that mostly participants had a positive attitude towards using an exoskeleton. The results suggest that exoskeletons can reduce perceived physical demand, temporal demand, and effort while improving comfort levels for certain body parts. However, the perceived effectiveness of the job was lower with no improvements in task performance. This highlights the importance of addressing design barriers to optimize the integration of exoskeletons into specific work environments and aligning them with the wearer's expectations of improving job performance. Some notable limitations associated with the study include the focus on subjective measures as opposed to quantitative measures like muscle activity, postural assessments, and heart rate. These are our references. Thank you very much for listening.
Okay, great. Thank you very much. And thank you, Jenil, for managing the videos for us. So two different presentations from our previous group. We'll open the floor up now for any questions or comments that the audience might have concerning the projects that were presented here. And Jenil, remind me, do we have 20 minutes here or 15?
20. We have till 10:45. Yeah.
Till 10:45. Okay, great. Thank you. So I'll get us started with a question for Ocean about the exosuit. I know when I first saw the presentation, it was a different style of exosuit than what I might have been exposed to before, but this is a less expensive option. I wonder what additional data has been provided, perhaps by the manufacturer, on some longer term studies on injury prevention in workers in different fields. Did they were they able to provide any of that kind of information that might be informative about how this might work long term? Because I think injury prevention is probably one of the key things that an employer might be concerned about versus managing fatigue, which is related but a little bit different concept.
So that's a very interesting question. So initially, the exoskeleton that we were going to work with was the most widely used exoskeleton out there, which is the I'm sorry, I'm blanking on the name, but it was I'm so sorry, I forgot what its name was, but it was by Humac. No, sorry. So it was a rigid body exoskeleton, which is, do you mind if I quickly like search what the name of the initial exoskeleton was? No. Yes, so it was an exoskeleton by Autobac. And so when we started with the rigid body exoskeleton, we found that there was a lot of research and a lot of data with respect to how effective this exoskeleton is and how well it's been researched and studied. But what we found was that initially, when we started the study and we started piloting, we found that this exoskeleton was not very comfortable to use, and a lot of times some larger individuals and typically the EMT workforce EMT workforce has a wide range of weight ranges. We found that some of the larger individuals were not able to use. So the decision to use the HeroWear exoskeleton was when so in my lab, my professor was already thinking of getting more soft body exoskeletons for other projects. So the HeroWear decision was a little bit last minute, and we found that the response to this exoskeleton was better. So our decision to use exoskeleton was more informed by the EMT experience rather than the research. But we are in collaboration with the manufacturers of HeroWear exoskeletons, and this is a relatively new product. So I wouldn't be able to say there's a lot of thorough research on this, but that's why we are collaborating with them to generate that data right now to see how useful it is and what are the shortcomings and what are the benefits of this soft body exoskeleton.
Great, thank you. And we do have another question for you in the chat here from Dr. Levine. He's asking, how does the TLX correspond to the NIOSH lift equation regarding assessing LS spine disc force reduction by the use of the exoskeleton?
I feel that's an excellent question because the NIOSH lifting equation would be the standard equation that you would want to use to assess any kind of lifting job. But the purpose of the TLX specifically was to capture mental workload rather than physical workload. There were other measures that we used. So we used discomfort in the lower back, and we also used perceived exertion to get that perceptional response to see how well or how badly people found the exoskeleton to be. Now we did not focus on the NIOSH lifting equation in this situation specifically because the tasks themselves were not purely lifting tasks. So the focus, a lot of the times, the focus of the EMTs is not just to do the task of lifting, but then there are some other tasks that are combined with the lifting tasks. So initially, rather than focusing on doing a more controlled evaluation of the lifting task, we wanted to test whether once the participants use this exoskeleton in a very ecologically valid scenario, which would be a combination of lifting tasks as well as other tasks like carrying, climbing stairs, etc., what their perception would be. But yes, in the future, I think we should also look at the NIOSH lifting equation, if that makes sense.
And as a follow-up to that, how long was the circuit that they performed?
Typically that circuit would last about 7 to 8 minutes. It had tasks that were so the longest task was 2 minutes long, which was the 2-minute CPR, and the shortest task was the backboard lifting task, which would typically take about 7 seconds to 8 seconds.
And then how many times did they complete the circuit during one of the testing periods?
So initially we started with them completing the circuit with 3 times. So 3 times in the exoskeleton condition and 3 times in the control conditions. But we did have some logistic issues because the study was going too long. So then later it was reduced to 2 circuits. So 2 circuits per condition. So 2 for exoskeleton condition and 2 for control condition.
Okay, great. And your participants felt like you saw less discomfort and less mental load reported by the participants, but they were about split on ease of use and whether or not they would be feeling like this would actually make them more effective at their job. Is that correct?
Yes, so it was a very interesting result, I would say, because a lot of these EMTs, the reason that we were able to complete the study and was largely because of the support we got from the specific fire department. So a lot of the EMTs that volunteered for this particular study were very enthusiastic about the exoskeleton. So they had their own expectations coming in that it will help reduce their load. So they did find that the experience with the exoskeleton itself was easy to so it was easy to use, it was easy to interpret and understand how to use it. They were quickly able to learn how to use the exoskeleton. But where they did not give a very positive response was that when it comes to my specific job of EMT work, that's where I'm not sure if the exoskeleton will be useful or not. So maybe they felt that they might require a stronger support than the exoskeleton was able to give, even though it was easy to use and easy to feel. But then again, that's why we had multiple measures, multiple subjective measures, because it might simply be the fact that the exoskeleton did not match their expectations. If that makes sense.
Yeah, that's a great point, especially with the change in the exoskeleton. So that's helpful to know. Thank you.
Yes.
Other questions?
Dr. Moore, I think there's Dr. Wong, Juyeon Wong. I think she has a question. I see her.
Sorry, thank you. I was having trouble seeing the hand raised. Yeah, Dr. Huang, please go ahead with your question.
Yeah, so I have a question regarding the exoskeleton fit. Yeah, so if I remember correctly, you have 2 female and 18 male participants, right?
Yes, ma'am.
So I was wondering, about any gender differences. Because sometimes not sometimes, it's very often the physical, it's totally different between the genders, or maybe some other phenotypes or demographic characteristics. So can you please explain to those differences?
That is an excellent question, ma'am, and that was definitely one of our primary concerns. So when we were recruiting participants, we wanted to have as much of a gender balanced participant pool as we possibly could, but simply because typically EMTs are very heavily EMTs are almost completely male dominated. We were not able to recruit as many female participants, but we did have 2 female participants. We did not see any statistical difference between them, but that might simply be because we have a very low power. So we did attempt to recruit as many female participants as possible. And so this is a pilot study. In the future, I do plan to do a larger study. So we will increase our efforts to recruit as many female participants as we can, so that we can do the statistical comparison. But I agree with you, that is definitely a concern, because historically exoskeletons have not very well, exoskeletons have shown to be a poorer fit for women as compared to men.
Dr. Dasgupta, I wanted to ask you a question related to the the stretch exercises for the construction workers. And so my understanding is that you had the professional come in, the physical therapist come in and sort of explain what were the benefits of stretching to the group, and then you saw a significant difference in interest about engaging in the pre-work stretching activities in order to reduce injuries. I'm assuming that's the approach that was taken by the physical therapist, was explaining the potential reduction in pain and injury prevention. Could you talk a little bit more about what the physical therapist was presenting to the group as part of your study?
I mean, I just got a text from Priya that her network is trying to reconnect and she's trying to call back from her phone. So you'll probably have to repeat that long question again.
Sure, no problem. Yeah, I'll be more concise when she reconnects because I've already formulated it once in my brain. So
yeah, no.
Okay, well, while we're waiting for Priya to reconnect, other questions for Dr. Tyagi? I'm sorry.
I'm not sure if I get the Dr. Tyagi status
Yeah,
yet because
sorry,
I'm right now
I
between my.
promoted you too soon.
Well, I did complete my defense, but I have not graduated yet, so I'm not sure.
Oh,
Yeah.
you're in that gray zone. Well,
Yes.
congratulations on having completed your defense. That's
Thank you.
great. Yeah. So I wonder if you could explain a little bit on the setup of the HeroWear. How are the elastic bands fit to the individual users? Is there an adjustment? Are there different band sizes?
Yes, so there are different band sizes and there are different strength levels as well. Is it okay if I share my screen?
Sure.
Okay. Let me share my screen too. So if you see this figure over here, so this would be the autobac exoskeleton, and the elastic bands that are here on the sides, they clip on to the exoskeleton. So in this particular area, there is that attachment where you can clip it on, and then you can clip it on the leg area as well. Where there's a very simple adjustment clip where it attaches very easily. So it's very easy to disintegrate and then assemble the exoskeleton. And the second thing is it is also very easy to change all attachments. So you can change the chest, the chest support, the chest frame. Then you can also change the size of these thigh supports, and so yeah, all of these are customizable.
When it mentions there's a clutch there, so is there a mechanism that's moving in that back support that's...
Yes. So let me see if I can make this figure a little bit bigger. Sorry.
I'm sorry, the engineer is asking you detailed questions here about how the device works.
No, of course, I'm happy to help. So yes,
Okay.
so if you see over here, so this is the clutch, and typically when there's a button on the shoulder in the front, and I did not share a front picture, to keep the anonymity of the participant. But there's a picture there's a clutch in the there's a switch in the front where you turn it on or you turn it off. So when you turn it off, basically there is a rope that so when you bend, there is a rope that just stretches as much as you need it to, and you can just bend normally. But when you turn it on, it locks in. So when you're bending, it's basically these high resistance band that are stretching in for you to be able to bend. So the bending action of going down is tougher on the participant, but then coming back up becomes easier because the bands support them to come back up. So that's the whole mechanism of this exoskeleton.
And then there are arm bands as well.
Sorry, so the armbands we also used, so the armbands are not a part of the exoskeleton. We also used motion capture, which I was not able to show the results because the data is still being processed. So that's for the motion capture sensors.
Okay.
Yeah.
So this is really focused on low back then.
Yes.
Okay.
I can stop sharing the screen.
Great, thank you. Jenil, has Priya made it back on the call?
No, I haven't heard back from her.
Well, since we won't be able to ask her any questions right now, do you want to move forward with our next set of presentations?
Yeah, we have 3 minutes followed by a 5-minute break. So maybe we can just wait on Priya because I sent her the whole document that has the phone numbers and the meeting passcode and all that if she can directly call from there. But let's see.
Ocean, what's the next step for your group on this project?
So right now we are currently in the phase of analyzing the electromyographic data, which is also what we collected, and the XSense data and the heart rate data. So right now for this particular research project, we are planning to analyze those 3 data sets, and then we expect to get another paper out of this this data collection. But so I would be joining Michigan Ann Arbor in August as a new faculty member, and I plan to submit a larger project. Like I plan to submit a larger request for grant from NIOSH to informed by this pilot data to do a larger study for EMT workers.
That's great. Well, congratulations on your new appointment.
Thank you.
Yeah. It's interesting also to hear that you all were collecting sort of 2 sets of data. You had the sort of what was the more subjective evaluation of the use by the participants, but then you have also some data to help you get a sense of their level of exertion, heart rate, these kinds of things. So.
Yes. So typically in our research lab, we try to collect both, because I always find that multimodal data collection is a lot more informative than just collecting subjective or just collecting physiological data. Yeah.
Okay, thank you, Ocean. She's saying she's there on the phone and she can hear and talk, but I don't think we can. Do we? No, so I guess we'll continue.
That's fine. We can
catch her up in the next session as well.
To.
Yeah.
Yep.
In the next discussion session as well. Yeah. Okay, so we are now approaching our second break, which will be for 5 more minutes. So we will resume at 10:50 for our session 3, which will be moderated by Dr. Casanova. Okay. That was quite short. So we are on time to start our session 3, which is on farm and other workers' general health, and I'll pass it over to Dr. Casanova.
All right, thank you all for hanging in. This is the 3rd and final group of the day. The group is farm and other workers' general health. We have 3 presenters. Laura Shea from the University of Texas Health Science Center at Houston School of Public Health, San Antonio will be the first speaker, followed by Rachel Hale from the University of Arkansas for Medical Sciences. And our final speaker of the symposium will be Andrea Gonzalez Mellinger. She is with the University of Texas Health Science Center at Houston School of Public Health. We will begin with Laura Shea.
Okay.
Hi, my name is Aubrey Shea. I'm an assistant professor at UTHealth Houston School of Public Health in the Department of Health Promotion and Behavioral Sciences. Today I'm presenting on our pilot project titled Chronic and Infectious Disease Risk Perceptions and Use of Preventive Care Among Household Cleaners in San Antonio, Texas. First, I wanted to share a bit about household cleaners and some of the health risks they face due to their work. Approximately 800,000 people in the U.S. were employed as maids or housekeepers in 2020. Texas has one of the highest concentrations of domestic workers, yet one of the lowest mean wages for this occupational group. Household cleaners represent an understudied and vulnerable population. Because of their heavy use of common household cleaning products and in-person encounters with clients, Household cleaners are at a risk for a multitude of occupational health hazards, including increased risk for several chronic diseases such as asthma and cancer, as well as increased exposure to infectious diseases such as COVID-19. In addition, household cleaners are at a high risk for not getting adequate preventive services, including asthma and cancer screenings. Household cleaners typically lack paid medical leave, and many are ineligible for employer-based health insurance, making access to preventive care more difficult. These same risk factors may also hinder access to COVID-19 screening. Our long-term goal is to increase access to and use of preventive healthcare services among household cleaners in San Antonio. The objective for this pilot study was to better understand the perceptions of chronic disease and COVID-19 risks, as well as barriers and facilitators to accessing preventive healthcare among this population. In this pilot, we've continued our partnership with Domésticas Unidas, a local grassroots organization in San Antonio serving household cleaners. This pilot builds on the previous work of my co-investigators, Drs. David Jimeno and Christy Whitworth. We used an existing cohort of over 60 female household cleaners in San Antonio who had given consent to be recontacted. Recruitment for this study followed protocols of the previous studies. We focused on females because male household cleaners are rare, and we were unlikely to get a sample size sufficient to make conclusions about this group. Our bilingual research assistant called and texted participants from the prior cohort. She explained the study to gauge their interest and scheduled them for an upcoming focus group. Focus groups were held on evenings and weekends to best accommodate the participants' work schedules. We conducted 5 focus groups with household cleaners in San Antonio, with a total of 18 women participating over the course of March and April. All focus groups were conducted in Spanish and led by our qualitatively trained bilingual research assistant. All focus groups were audio recorded, and their recordings were professionally transcribed in Spanish and then professionally translated into English. I conducted a qualitative thematic analysis of the English transcripts using Atlas TI-22 for coding. Themes were identified across the 5 focus groups. Years of experience as a household cleaner among the participants ranged from 1 to 31 years, with a mean of 13 years. Participants reported a range of health effects that they attributed to their work as a household cleaner, including skin effects, asthma, muscle pain, and arthritis, among many others. Most participants were quite knowledgeable about cancer screenings such as pap smears and mammography. Many reported accessing these services at local, free, or low-cost clinics and health fairs. The women were less knowledgeable and less likely to have had colorectal cancer screening. Of note, they said they could not access a colonoscopy at health fairs or free clinics, and so for many it was cost prohibitive. In one focus group, when asked why they had not received colon cancer screening, 3 women had the following conversation. The first said, "I did not know that women had to do that." The second said, "I only always heard about pap smears and about breast cancer. It never crossed my mind that I would have to have a colon exam done." The third woman said, "I did not know that a colonoscopy detected colon cancer. I thought that the colonoscopy was prescribed or indicated to someone who had digestive problems. Just last week, about 15 days ago, my boss had that test, and that's when I found out that women also do it after a certain age. I've never done it." The second participant agreed, saying, "It is that we lack information." Very few of the focus group participants had received any screening for asthma. One participant noted, "Many times the test for a woman, the pap smear, the mammogram, there are places where they can be done, and sometimes you can get them for free. But as one who works with chemicals, why aren't there x-rays of the lung, of the respiratory tract, of the nose? How come there are no tests for those of us who work with chemicals?" Most participants felt that they were at an increased risk for COVID due to their occupation as a household cleaner. Most participants had received at least 1 COVID vaccine, but many were hesitant to get more due to fears about side effects. All reported that the access to the vaccine and COVID testing had been easy. While most participants reported that they could visit a doctor when sick or stay home from work if needed, they reported a difficult decision between taking care of their health and receiving income to support their families. While a few of their employees paid them for sick days, most reported that they were not paid if they called in sick. When asked where they go for care, many mentioned a local clinic system that provides free and reduced cost care for those without insurance. Several mentioned health fairs and clinics that they learn about through churches. Still others described traveling back to Mexico for more affordable care, although this option was not available to undocumented workers who cannot travel back and forth over the border. Results from our focus group highlight several areas for intervention, including policy advocacy, educational programming, particularly around colon cancer screening and vaccine safety, and improving access to high-quality, low-cost care. I want to end with a quote from a participant about policy change needs. What you see is that employers pay us for sick leave according to their will, not because the law establishes it. So that's what one has to fight for, the right to be recognized as workers. But Texas law does not protect us as domestic workers. He could, if I were to get sick, tell me, okay, we don't need you anymore. And I'm going to be left without a job and without a way to support ourselves. That's the hard part of working as a domestic worker. I would like to acknowledge our partner, Domésticas Unidas, all the participants for generously giving their time, my co-investigators, Drs. David Jimeno and Christy Whitworth, and our wonderful research assistant, Andrea. And of course, thank you to the Southwest Center's Pilot Projects Research Training Program for the Pilot Award making this work possible.
Hey everyone, my name is Rachel Hill. I'm with the University of Arkansas for Medical Sciences, and I'm excited to be here to share about my pilot project that was recently funded looking at the overall health of small farmers in Arkansas alongside their climate change and health beliefs and risk perceptions. So the plan for today. The plan is to give everyone a snapshot of how climate change impacts human health, what we know and don't know about farmer health and the impacts climate change is going to have on their overall well-being, a little bit about my project, and then why this research is important. So this slide is going to show you how climate change impacts a wide range of health outcomes. It shows the most significant climate change impacts, their effects on exposure, and then the subsequent health outcomes that can result from these changes in exposure. All our small farmers are going to be impacted quite greatly from climate change. What we know that small farmers are highly vulnerable to the effects of climate change on their physical and emotional health. They're already facing an increase in heat-related illnesses alongside work-related injuries and death that impact their individual health and their family's health. We also know that small farmers are facing a reduction in workable hours as well as a physical inability to cope to our changing climate, and this may lead to higher levels of food insecurity as well as poverty. We may see an average number of hours working in unsafe conditions double by the mid-century if we continue with our current emissions. We also know that within the U.S. and globally, small farmers are already reporting increases in anxiety and depression about climate change, the impact it's going to have on their family, their livelihoods. We also are seeing an increase in pesticide exposure due to pest population habitat growing and lifespan. Why small farmers? Small farmers are highly vulnerable to the effects of climate change, and this is due by looking at the intersection of exposure and sensitivity to the threat of climate change, which is then mediated by the capacity to adapt. That is how we assess climate and health vulnerability. And then within the small farming community, there are communities with heightened vulnerability. Climate change interacts with the social determinants of health, which exacerbates their significant role in affecting farmer health. Climate change is a threat multiplier. And this brings us to what we don't know. Well, currently we lack overall health data that can tell us the prevalence of illness and work-related injuries of small farmers. So really, before we move into designing interventions to reduce risk, we have to identify the areas of vulnerability for this specific community and understand how they're already adapting. This brings us to my pilot project, which is a survey that is going to be assessing the climate change and health vulnerability of our small farmers in Arkansas, looking at various variables in hopes to start identifying ways that we can build future interventions to improve their overall well-being. And we need to address the issue in the room. Climate change and the word global warming are not words that are often welcoming to a conversation. They can be polarizing and off-putting, so we're looking at discussing this within the survey by using the terminology of our changing climate. The health belief model is a theoretical model used to explain and predict individual changes in health behavior. So I've used the health belief model constructs to guide my survey questions that are on the climate change and health to potentially identify perceptions that may hinder or enable small farmers from enacting change to protect their health. The project is hoping to address a knowledge gap, and that is really the overall health status of small farmers in Arkansas, their demographics and farm characteristics, alongside the climate change, health beliefs, and risk perceptions, and their current adaptive agricultural practices. You may be asking yourself, okay, so what are you asking small farmers? So we're going to be providing a Likert scale around the climate statements. I believe our climate is changing and getting warmer. I believe people are responsible for the changes in our climate. I can adapt to the risk and problems from our changing climate. And to provide you some examples of the questions we're asking about their agricultural practices, we want to know if they've already implemented agri-solar, crop rotation, drip irrigation, no-till, hydroponics, diversifying their crops, growing alternative protein sources, to name a few. And alongside the health belief model, we are going from the total worker health approach. And that is what is driving our target population, being owners and co-owners of small farms, because a defining element of this approach is developing leadership commitment to occupational safety. So looking at who we're talking to, we want to talk to 18-year-old farmers who own or co-own a farm that their gross farm income is $250K or less. They can speak English or Spanish because we have the support of the Center for Health Literacy for Spanish translation. We're aiming to collect about 200 surveys. We have amazing community partners located across the state that are excited about this project, that are going to be collecting surveys for us. I also have a STED scholar that's going to be traveling to farmers markets and community events. We're excited to get this survey out there and that we're able to provide a $20 gift card to each participant. This research is important because we need to assess and capture data that tells us where are we now in order to develop future interventions that can improve the overall well-being of our small farmers, decreasing their work-related injuries and illnesses as our climate continues to change. None of this could be done without the funding that I have received from the Southwest Center for Agricultural Health, Injury Prevention and Education, community partners, my mentor, the Department of Health in Arkansas, as well as my institution. Thank you so much.
Okay, and last but not the least, we have Miss Andrea Bellinger Gonzalez.
Hi, my name is Andrea Gonzalez Mellinger. I'm a recently graduated master's student in the Department of Epidemiology, and I am presenting my project on the effectiveness of a cooling vest and biomonitor to prevent heat strain in construction workers. I wanted to take a moment to acknowledge Dr. William Brett Perkison, who is a practicing MD and an expert in occupational health medicine. He is my co-PI and mentor for this project. I also wanted to extend a big thank you to our student collaborators, Josh Lato and Rosalia Guerrero, and Dr. Sirikul and Dr. Kevin Lanza, who are heat experts and have been instrumental for our study design. We're all aware of the growing threat that is posed by climate change on heat-related illness. You can see on this slide a site very similar to our own, where the workers are actually climbing up these rigs and pulling giant cables, often little to no shade. And although they can take breaks, this is a growing concern, and CDC has done some great reporting on how heat waves have increased emergency department visits across the country. Little to no shade. The military has a wealth of information and they have been pushing the envelope since the 1950s in this area. They are now pushing to use personal monitoring devices that take into account individual differences such as body composition as well as prior heat injury. To take that from the military context and apply it to construction. So we came up with this design, which is a case crossover trial where participants serve as their own control to increase internal validity. We have a sample of 14 wire pullers who are randomized to 2 groups, and one day they'll wear both the biomonitor and the cooling vest, and on the other day they will wear only the biomonitor, and we will compare results between intervention and non-intervention days for each person. Here we have a visual of the cooling vest. It's a lightweight vest with ice packs that need to be changed out every 2 to 3 hours, and the biomonitor, which you wear under your shirt directly on the skin. Biomonitor is going to collect these variables that we have listed here in the schedule of measurements. We're going to take demographics and medical history before the intervention. During, we have them listed, as well as the environmental variables and perceived symptoms. After that 2-hour session of monitoring, we're going to give them a survey where they'll tell us their perceived heat stress symptoms and also questions about feasibility and implementability on the job site. Unfortunately, data collection was pushed out to the end of June due to storms in Houston, but our predicted outcomes are that there will be decreased perceived thermal discomfort on the days when they are wearing the cooling vest, as well as higher heart rate variability, that is decreased automaticity of the heart as an early sign of heat stress, which is a measure that is currently under investigation. We hope that the results obtained from our pilot study will be incorporated into a larger R01 grant that can demonstrate the benefits of cooling vests in a larger working population for an extended period of time. The literature to date has been almost exclusively executed in lab settings, and the novelty of our study is that we are bringing it to the field site to see the implementability in a real life situation. Obviously, real life settings pose real life problems, and I already mentioned the weather, but recruitment and retention is another barrier that needs to be addressed with IRB, and making sure that you get enough face time for the participants to make their own decisions and not just hear about it from management, as well as working with the shifting timelines of the fracking projects. You want management to be involved so that they can center the workers who most need these interventions, but a lot of the time they don't know when they're going to finish one piece of work and who's going to be on site those days. So these are all things that need to be worked out. Recommendations for overcoming these barriers are making sure you have a really close relationship with the field site and are communicating about the shifting needs of the work. They need to be shaping the protocol, so they need to be in talks before IRB approval, but also during and after. By the time these field sites are very remote, and you need to make sure that you are prepared for not having cell phone service, figuring out parking, and leaving ample time before any deadlines to make sure that no surprises. Thank you so much, and I am open for any questions.
Thank you to all the presenters. Excellent presentations. And Jenil, how much time do we have for questions?
We have till 11:50. We have 40
Perfect.
minutes, but we can end it early too if we don't have too many questions. We don't have to wait till 11:50.
Right. So our presenters are ready for questions. Please raise your hand or type it in the chat. I will start off with a question for Rachel. Give me an idea of your timeline and then also numbers. How many folks do you anticipate surveying?
I'm on an 8-month timeline. but we hope to collect over the next 2.5 months. We'll be doing data analysis as we collect to make sure we get like a diverse sample. We aim to hopefully get 200 surveys, if not more. We do have enough due to like UAMS funding to provide more participant incentives if possible. So we hope to have the results at the end of August. That's the aim, but we are also prepared for life happening sometimes.
Thank you. We do have a question in the chat. I'm sorry, we don't have a question in the chat. I didn't scroll down. Let me see.
Neil's got a question.
Yep, go ahead.
Yeah, so I have a question for Dr. Shea. I think this was a great presentation, and I myself have been involved in some studies related to cleaners, and this was really great to know. And focus group data is always so important in moving forward. So I was just wondering what the next steps are for this study. Are you planning to do like a larger study to evaluate these risks and infectious disease risk and perceptions, and what are the next steps involved?
Thanks, Dr. Patel. We're still thinking through that, but definitely there's a few areas where we're finding from these focus group findings of areas of need. Some of them are maybe a little simpler, they're educational needs. Most participants did not know about colorectal cancer screening and the need for that among women. There was just a misperception that that was a male thing to do, or that it wasn't about cancer, it was just about diagnostics. And so working with our partner Domesticus Unidas, we could definitely work towards providing an educational intervention that way, or more broadly through the groups. The other thing that they seem very interested in is advocacy for policies around sick leave, and that's another thing that our partner DU does a lot of, is helping them understand their rights and working towards that. And so I think partnering with them to help the cleaners themselves push the agenda for what changes we can make. We do hope that this will for sure be a paper and then move on to a larger study, but we're still kind of figuring out exactly which direction to go with that.
Absolutely. I would have loved for Dr. Henneberger to be here, because you had these asthma screening component there, and he has done a lot of work on asthma. And one of the projects was where Dr. Jimeno and I and Dr. Delcos were involved, in which we looked at certified nurse aides who were involved in all these cleaning tasks using disinfectants and all. And they had a much more higher risk compared to other healthcare workers. So I hope you're able to move into that direction as well, and see where the respiratory conditions and all lie in this whole spectrum. So,
yeah,
but this is a great study. Yeah.
Thank you. Yeah, great point. I forgot to mention that as well, that they definitely were saying that they feel like there should be screenings for this. And we know that there are screenings and there are treatments. And so there's a lack of knowledge and then lack of access as well there that we could definitely work towards intervening on.
Thanks. You have enough questions coming up, so I can see a lot of reasons.
Yes, Dr. Z?
Good morning. Question to Dr. Gonzalez-Mellinger. I understand that some of the tests, pilot tests, have not been fully performed for various reasons, and they're scheduled for the end of June. What was the basis foundation for prediction about change in heart rate? Thank you.
Yeah, so this is from preliminary research that's been done in military studies with personal monitoring, and we were hoping to see if we see more heart rate variability and early signs of heat stress. Obviously, because it's a just pilot trial, it's going to be difficult to really make those types of associations because we don't have a full working day. But we just wanted to put it as an aim so that we could continue to add to that literature.
Thank you.
Dr. Moore, you have a question?
Yeah, Dr. Shea, did you find in your study that the cleaners had a good understanding about the potential hazards of the chemicals that they were working with? So I'm just wondering, from a HAZCOM point of view, you know, do they feel like they were adequately aware of what some of the potential hazards were of the chemicals, and what are some of the issues related to you know, how we might do a better job of informing them about what some of those hazards might be?
Sure, thanks. Great question. We were asking about a wide range of topics here, so we did talk about chemicals, but we didn't get into the specifics of them knowing which chemicals do what. But yes, that was the number one thing, even without prompting, when we ask, are there any, do you think you're at any increased risk for health issues due to your work? Chemicals comes up first. So they're very concerned about and worried about chemicals. Through Domesticos Unidas, some of them have learned to mix make their own cleaning supplies with like vinegar and like natural cleaning supplies, and not mixing chemicals. Sorry, it sounded like I was going to go there. And so some of them are already thinking about that, but they did mention chemical exposures. Some of them worrying about saying they have chronic sinusitis or like nasal issues, breathing issues, and then a lot of discussion about skin issues. And actually, to be honest, I haven't looked this up to know, but many of them were concerned that the products they were using might cause skin cancer. I actually don't know if that's true or not. So there are questions that they have, and it doesn't seem like all of their questions and concerns are necessarily informed by science or research based. So I think there's definitely that as well. And I do think that there's other projects going on with this group to look at that as well, about chemical exposures and actually measuring the level of chemical exposures they have.
Can I just jump in really quickly, Dr. Shea? Has there been any work on slips, trips, and falls with this work group?
Dr. Jimeno, I'll ask you.
Yeah, I'm going to jump in. Thank you, Vanessa. So two things. This is a group of women that we've been following since 2017. I mean, it's kind of an open cohort, really, because some people drop and, they leave the country and so on. But we have a current NIHS study on VOCs, the volatile organic compounds. So we are tracking that exposure in terms of the chemical. It's not every chemical, but it's the VOCs. And the other thing we ask them is about their tasks they do at home, like they clean toilets or they clean windows and so on, and the type of products they use. So we are working on that. We don't have any ergonomic study. We do ask some questions about, do you have an injury and so on, but that's kind of the next step, thinking about the group really. One is this educational intervention of access to healthcare and where are the resources and, etc. And this pilot was kind of that initiation phase, like, is there anything there? And I will say that this sort of came from them saying, we have problems with cancer, we have problems with this, right? And it was from the group us generating the research idea. And the other thing then is the ergonomic, because part of the issue, we know that they have a lot of musculoskeletal issues, not necessarily injury. It's sometimes with certain Hispanic population, it's difficult for them to report that way, but they report, a lot of issues with their hands because they are, scrubbing and then they are mopping. So there is a lot of back pain, low back pain, and so on. We do know in terms of trips that certain type of trips really do not really happen at the home, but it happens when they go into the house because they may have a slippery surface, particularly modern houses where the concretes are too new and they sleep. Some of these women are, 50s and above, and they've been cleaning houses for 30, 35 years. And the other thing is in the modern house, let's say, they are not housekeeping friendly in terms of tall windows, and they report this thing more in the injury side of the story, that they need to go up and down the ladder, move the ladder, clean it, move it. So that's why it's prompting that we are probably going to work on, maybe not for October, but maybe for January, on one more on the ergonomic side, injury falls and trips.
Thank you for that. Well, it's been many years, but I read something similar with hotel housekeeping, and the number of pillows on the beds these days, things like that, just changing. Thank you. Dr. Wong has a question, and then Dr. Perkson.
Yeah, I have a question regarding Dr. Shea's presentation. So that was very interesting, and I assume that the most race is maybe the Hispanic in your cohort. And then I wonder if you actually, tailored your perception questions with like culture based. Is there any some unique perspectives or perceptions of their culture?
Great question. Yes. All the participants were Hispanic. All participated in Spanish language focus groups. So the quotes you saw were transcribed and translated from the audio. So we definitely, like Dr. Jimeno just said, the questions that we were expanding on in this project was really driven by their concerns, which is the same population and some of the same sample. So in that way, it was it was tailored to their concerns. We also have native Spanish speaking co-investigator, Dr. Jimeno, and graduate research assistant who led the focus group. So we made sure that the way the questions were asked were not just in Spanish translated, but like culturally appropriate. But it's a good question. We don't have a comparison group here to know if there's cultural differences in some of their perceptions here, because this is solely Hispanic population that was in this focus group study. Great question.
Yeah, thanks. All three presentations, really good, really enjoyed them. I had a question for Ms. Hale regarding the perceptions of agricultural workers regarding climate change. It may be beyond the scope of this initial study, but do you see trying to expand that at all into how farm workers feel about policy changes, relating to climate change? I mean, it's such a their input is so unique regarding mitigating climate change as well as disaster response, which is sometimes not really geared towards people in rural areas.
Definitely. My mentor and I, we have discussed, further funding because it is beyond the scope of this project, but looking at farmers as through like collecting qualitative data through interviews and focus groups to determine kind of where they would want to go with policy, how they feel about it right now, and what changes they would want. And we would probably want to identify like a local community partner. Most of the research that I have done has been community engaged research. So I would like to have, a co-investigator that is a farmer, or at least with an organization that works with that one. But I do foresee them being a big community that could enact a lot of change in order to better improve their own livelihoods and then farming and in the rural communities in general. So yes, I mean, that's definitely on the horizon, I think.
Thank you.
Any other questions for this group of presenters?
Yeah, I have another question to Andrea. Yeah, so about the cooling vest. Yeah, so if I understand correctly, you measure the physical activity and maybe perhaps core body temperature as well. Yeah. Okay. Yeah. So that definitely increase that those respiration as well as metabolism, right? So I wonder if you, have considered for your future directions to maybe measure those metabolism or metabolites from one of your biomonitoring program. Yeah.
Yeah, that's a great suggestion. Currently, we are only measuring hydration through specific gravity of urinalysis at the beginning of the test session, just to make sure that it's not affecting the pilot. But going forward, that would be a good thing to consider. So thank you very much.
Dr. Moore, please go ahead.
Rachel, I was wondering if you might comment a little bit on some of the feelings of helplessness that might be experienced by the farmers related to climate change. This is something they have to manage, but they also are sort of powerless to make any changes on their own. So I'm wondering how you might be considering that as part of your study.
Yes. So I think that goes into kind of their adaptive capacity, like even just the mental load that it's going to take. I can share, I did an interview, so this is not part of this study, but I did an interview with a small farmer when I was designing this instrument to kind of gather a little bit more information. Helplessness did come out, and it did talk about, I'm a small farmer. Farming is not my primary occupation. I also have another job. And so I plan out my year in advance of when I'm going to plant, when I'm going to do this, when I have off based upon my other job. So if policy or when the climate forces us to change, that's going to be something that they have to consider. Do I want to consider farming in general? Do I just want to shut it down now because I don't think it's feasible? What are the available resources out there that can let me slowly start adapting now? I think one of the things that I'm hoping after I gather this data is to figure out, okay, for those farmers that are interested and have the ability to incorporate new practices, what are the available resources for them and how can that improve their life, their family's life? And for those that, I think, working, we also have the cooperative extension here as well. And they do a lot of stuff around farmer mental health. And I think that's going to be an important component to bring in to address a lot of this. I see it, I'll speak personally within my family that are farmers, that it is something that they think about daily. Do they think about it in the context of climate change? No. They think about it in the context of the floods are coming a little bit more, the rain is a lot heavier than it used to be. We're seeing tornadoes more. So it's learning the language. And I think hopefully that's one thing that I will gather too in further studies. So that was a long-winded answer, but yes, I'm very interested in addressing the helplessness of the feelings that come up. Yeah.
That's great. Thank you. And I also appreciate the comment related to supplemental employment and part-time farming and these activities is very, very common and something that also adds to the stress that these farmers are dealing with. And, not only are you trying to beat the weather, but you're also dealing with the fact that I don't have full control over when I can get out into the field. So that's a really, I think, important observation and an interesting point that you bring up about that. So thanks for mentioning that.
Thank you.
Dr. Z, you have another question?
Thank you. Good morning again. And the question is to Dr. Gonzalez-Mellinger. Again, a great presentation. Maybe I missed it because I joined through the middle of the question about the design of the cooling ice vest. Did you make the design or was it used from some other uses applications? Thank you.
No, this is like a well-established cooling vest that's used throughout different industries, including construction in some cases. It's called the Zephyr cooling vest. It's like a lightweight phase change vest. It's very compact and it has pockets that keep these ice packs in them. There's different models. Some of them have fans to keep cool, but I did not design it.
Thank you.
Can I follow up really quickly? What is your recruitment plan? You mentioned that as a potential barrier, but what's your actual plan?
Yeah, so with our recruitment plan, they have safety meetings. We're partnered with S&B Construction in Baytown, Texas. And so we have flyers that we've distributed to S&B, and they are going to distribute them to the workers in the safety meetings that they think have the most sun exposure, which is kind of what I was addressing with those like tight timelines and shifting nature of the work, because sometimes they're pouring cement, sometimes they're pulling wires, and it just depends on what stage they're at, and they kind of just finish when they finish. So it changes the population that we're working with, and it did end up changing it for us. So they are going to distribute the flyers. Workers who are interested are going to come to our orientation, which is actually scheduled for this Monday. And then we're going to give a presentation and collect a contact list of people who want to be involved. And basically the first 14, we will consent either later that day or over the phone and get their demographic, family medical history in a private setting. And yeah, go from there. Our pilot test trial is later on that week. So anyone who wanted to participate, they do have another opportunity when we're on site on Thursday before the trial to get consent in a private setting.
Great, thank you so much. Any other questions for this group of presenters? Okay, I'm not seeing anything in the chat either, so I will pass the baton to Jenil and Kevin. Thank you all to this group.
Thanks, Dr. Casanova. Again, this was a great session as well. So thank you so much. Thanks to all the presenters for your wonderful presentations, and we love this Ignite format just for the fact that it's not just a traditional PowerPoint presentation that starts from background and ends with a conclusion, but it's more of a storytelling approach, which makes the audience more excited and thrilled about these projects. And as you all saw, that the conversations that happened were really helpful in moving this whole thing forward. So I really appreciate all of you for sending us your presentations, for all the great work you do, and for keeping these pilot projects programs on both the institutions going on. So with that, and also a big special thanks again to Dr. Henneberger for his wonderful talk. You all will be amazed to know that this is his last year at CDC NIOSH, and he's planning to retire. So we really got him on time. So if you have any questions, or if you want to learn any of his projects, right now is a good time to approach him. We'll be happy to share his contact information. Just email me or Dr. Moore, and we'll be happy to make that conversation possible for you all. So a big thanks to you all from the Southwest Center at UTHealth, as well as the Ag Center, and I'll pass it on to Kevin for some final words.
Sure, yeah, I want to thank Silvia Santiago for her work behind the scenes in organizing our speakers, coordinating all the activities, making sure that things continue to move forward.
I second that. Thank you, Silvia.
Yeah.
Yes, totally. Silvia has been up to the mark for getting everything on time and keeping us aware about what's happening and when are things due, and it wouldn't have been possible because this is a big organization between the two institutions. So thank you, Silvia. Definitely, yeah. And Dr. Jimeno, any words from you?
Well, thanks to everybody for attending and participating, and I guess we'll see you next year. Keep posted on the pilot projects side of both centers, and let's make something great.
I would definitely also just encourage everyone that's in attendance today to consider submitting a proposal for a future pilot feasibility study. I know that there are some great ideas out there, and we would love to visit with you about a potential project that you have. So please reach out to me or Jenil if you have a project idea that you want to try to discuss. If you're not quite sure which center it might fit with best, we can get together and have that conversation and talk through, what does your plan look like? Who are you engaging, and how might we help you in doing that more effectively? We can help with getting connected to resources and mentors and developing your study plans and all of these things. That's part of what we try to help do here. So if you or perhaps a graduate student that you're working with might have interest, please have that conversation with us, and let's see how we can help to support you moving forward.
Okay, so I guess we can call it off and give you all some 20 minutes on a Friday, which I'm sure everyone will be thankful for. Thank you, everyone. Have a good weekend.
Have a great weekend. Thank you
everyone.
all.